Okay, tracheostomy is basically a medical procedure. Either it is a permanent or temporary. Actually, this operation consists of making an opening in the anterior wall of the trachea and then converting it into a stoma, that is a hole. Either this hole would be a permanent or temporary on the skin surface. So, what are basically functions of tracheostomy? As we can see that in this case, we are going to place a tracheostomy tube in the trachea. So, it bypasses the, it actually gives air into the lungs. So, it bypasses your mouth, nose, and throat. So, basically, what are the functions of tracheostomy? Main aims are, that is, of course, it gives an alternate pathway for breathing and improves alveolar ventilation by decreasing dead space by 50% and protects the airway, of course, because most of the time we use cough tube against aspiration. Normally, whenever we will do the tracheostomy, immediately patient starts aspiration. So it will definitely one of the factors which protects the aspiration. Now, removal of secretions definitely if the patient is in ICU or he's in a comatose condition, he has many injuries, so they cannot cough properly. So multiple and a lot of secretions are piled up in the throat. So this is one of the way to immediately clean those secretions. And the next one is either patient on the ventilator. Just to put the patient on ventilator beyond 72 hours, then we need to do the tracheostomy, then the intubation. That is our so another factor is to administer anesthesia in difficult intubation. For example, laryngopharyngeal tumor, trismus, if there is a severe, trauma of the face, mandible, and it is very difficult to introduce endotracheal intubation, then it is a preferable procedure to do the tracheostomy. So there are different types of tracheostomies we can use. You can see this is one of the plastic tracheostomy tubes which we use normally, and these are the metallic tracheostomy tubes, and most of the time it is used for a longer period, while these are used for emergency as well as for elective procedures. You can see this is the hole which is present on which we are going to make after tracheostomy on the skin in front of the neck. So, what are the indications? There are actually three indications for the tracheostomy. Either the respiratory, definitely one of the causes, respiratory obstruction. The other is routine secretion, and then third one is respiratory insufficiency. What are the conditions which can present in the respiratory obstruction are basically the different inflammatory conditions like acute epiglottitis, bronchitis, trauma, tumors, different type of tumors present in the pharynx, larynx, tongue, and of course, definitely, if there is any irritation or inflammation of the larynx, then it is very difficult for a person to breathe. Then this is one of the indications for tracheostomy, and then of course bilateral abdominal paralysis. And it is mostly done during the thyroid surgery, elective surgery. This is one of the complications of the thyroid surgery. So in this case, we can do the permanent tracheostomy. Some conditions which are definitely congenital, laryngeal web, sometimes stenosis, subglottic stenosis. In this condition, we need to do the tracheostomy in young kids as well. So the other condition is retained secretion. Again, these basically retained secretions are present in those patients in which they are having some, they are unable to cough and they have some painful cough like chest x-rays, lip fractures, and then, of course, aspirations of nasal secretion. This is basically the procedure of the tracheostomy, what we exactly do in tracheostomy. As you can see that there are actually two procedures. Either it is an elective procedure or it is an emergency procedure. In both procedures, this vertical incision should be given between below the cricoid cartilage till the your substernal notch. This vertical incision, of course, there is another incision that is transverse incision we can give during elective procedures only, not for the emergency procedure. And that scar wall is more, cosmetically and friendly, and then it will heal, properly. While in the case of this will, of course, again heal up, but there is some cosmetic issue present with the vertical incision. Okay, but we do this vertical incident during emergency as well as the elective surgery. So what we exactly do, we around do this type of 2 to 3 centimeter incident below the trachea cartilage because we need to. हाँ बता दूँ So what we exactly, of course, we need to incise the skin, and then what else comes behind is basically strap muscles that are mostly strap muscles, and you can see. And the important thing which we need to do during tracheostomy, which will can give the complication is basically thyroid isthmus. So we need to retract the thyroid isthmus because whenever if we touch this thyroid isthmus, then it could bleed then there would be a lot of hemorrhage in your surgical side. It is very difficult to find out your trachea. Now you can see after retracting thyroid, then we can easily see the trachea. And we need to, give insulin in this trachea. That is the, sometimes horizontal insulin. But we need to spare the first tracheal vein because if we do the upper tracheostomy, then if we include the first tracheostomy vein, then it could later on give the complication of subglottic stenosis, which is a very difficult condition, and this condition might require permanent tracheostomy later on. So you can see that after incising this trachea, you can put this type of tubes in it, and it should be properly stabilized, and this can be stabilized this should be stabilized rather with the sutures. So again, I have talked about the permanent tracheostomy. In which condition we require permanent tracheostomy basically? In case of CA larynx or laryngectomy, because in that case we have to remove whole tracheal trunk from it. So there won't be any problem for the subglottic stenosis and infect because we need to remove all things during the laryngectomy. So permanent tracheostomy is done in those cases. While percutaneous dilatation tracheostomy is one of the types of the tracheostomy in which, and this is basically important for those patients who are present in the ICU, and we don't want to shift them from ICU to the OT theater due to some, hospital-induced infection. So in this case, we use flexible bronchoscope with camera is passed through endotracheal tube for guidance and dilators, and then tracheostomy tube is passed through the space through second and third rings of trachea. This is very important. It comes in your MCQ as well. So you need to know why we spare first tracheal ring and what is the complication occur if we include the first ring in our tracheostomy. So what is knee tracheostomy? Knee tracheostomy is an emergency procedure where insulin is made in hypothyroid membrane and tube is inserted. This is what is that we need to convert it into the normal tracheostomy because if this will stay for a long time, then again the complication, which are the important complication of the tracheostomy are perichondritis and subglottic stenosis. So again, I have talked regarding the high tracheostomy, mid and low tracheostomy. This is basically why we call, in which situation we call high tracheostomy, when it's done through the first and second ring of trachea. So we are including first tracheal ring. So again, the most important complication is subglottic stenosis. You may get scenario-based question on this, that patient is having his tracheostomy, and then later on develops subglottic stenosis. You should know the complications of the tracheostomy and why we are doing first high tracheostomy. What is mid tracheostomy? This is basically done in routine. That is through second and third rings after dividing thyroid. So a low tracheostomy, of course, is done third and fourth ring. But again, important thing, if you remember the anatomy of the trachea, then you can, say that yes, you can see that there are a lot of very important vessels present in the lower area below. So we are very close to those large vessels. Again, we were talking about percutaneous tracheostomy. You can see this. This is patient that is into in comatose condition. And what? So you can see that, of course, the procedure is same in the neck. We need to incise the trachea, but what we exactly do, because patient is not is properly anesthetized and we don't want to shift him from the ICU to the theaters, so we need a bronchoscope and pass the dilator through it to identify this place. And then, of course, we will do the same, pass the tracheostomy tube in this area. So again, post-op care is very important. Just imagine, because whenever we do the tracheostomy, what we exactly lost? The loss is we have a loss of our voice. We can't talk. So we need a constant supervision for this. Either you can place some bell close to the patient, or some attendant should be present till 24 hours. And later on, of course, then we need to teach the patient that he will, whatever he feels, if he is having any problem, he can write. If he can't write, either he can, tell with some signals. So, and again, another important thing, that after tracheostomy, initially, first 24 hours are very important, because there might be some retained secretions present over there. And we need to remove those secretions. So continuous suction of the secretion is very important, and it should be done with some catheter, proper catheter, and continuously with some suction tube. And prevention of crusting and tracheitis, of course, these are the complications. So need to do the continuous that is suction. And care of tracheostomy tube, of course, inner cannula removed and cleaned frequently, and cuff tubes deflated to prevent pressure necrosis. So whenever we do the tracheostomy with the plastic tubes, especially cuff tubes, then in our notes we need to tell the patient or the attending nurse that it should be deflated. The cuff should be deflated for 5 minutes for next 12 hours in 1 hour. And this will basically prevent the pressure necrosis. And another important complication which can occur is the decannulation. Means that we want to remove the tracheostomy tube, but what are the different conditions in which we are unable to do the decannulation. So in infants and children, decannulate in operation theatre definitely, because and this comes in your some SEQ. What are the conditions for unsuccessful decannulation? Why we are not, we are unable to remove the tracheostomy. Basically, what are the causes? Number one might be that the condition which the patient is having, it is persistent, and some, of course, granulations present around the hole. And whenever we want to remove the tracheostomy tube, there would be some, immediately necrosis, some cyanosis or difficulty in breathing. In that patient will come. And subglottic stenosis. If we place the tracheostomy tube for a longer time, then this condition would occur, that is subglottic stenosis. Tracheostomy is a dilatation of the tracheal muscle, so there is a tracheostomy, and sometimes in some patients there is a psychological dependence on tracheostomy. An endoscopic examination of larynx, trachea, bronchi, then it is needed in those conditions when there is the decannulation is not successful. Again, these complications of tracheostomy are very important. You need to learn it by heart, because any scenario can come with any of the complications. So you need to learn that, of course, the most important complication is hemorrhage, either during operation, or it could occur later on after, when the patient would shift in the ward. So apnea, yes, immediately it is there would be no breathing. Patient, ideally, the patient should breathe through the tracheostomy tube, but in some cases the apnea occurs. What is apnea? It is the sudden washing out of carbon dioxide, which was acting as a stimulus. And what is the treatment? Because this condition would occur in the theatre. So the treatment is 5% carbon dioxide in oxygen or assisted ventilation. Pneumothorax in infants due to injury to apical pleura, that is lung. Apical portion of the lung is very close to the And there are other complication is aspiration of the blood or injury to the esophagus. If we go down, then we could damage we could injure the esophagus. Now, intermediate complications during first few hours of the day. First hour of the first day, that is again hemorrhage. When we shift the patient to the theatre, hemorrhage is one of the complications. Or during shifting of the patient, there might be displacement of the tube. Blocking of the tube is very important, so continuous suction should be done. Subcutaneous emphysema, crusting in trachea, tracheitis, this is an atelectasis in lung abscess. This could occur only when we go very low down and we damage or injure the pleural apical portion of the pleura. So late complication again hemorrhage, but in this case due to major vessels and laryngeal stenosis, tracheal stenosis, tracheoesophageal fistula can be occurred due to pressure necrosis by the cuff tissue. So we need to continuously deflate and inflate the tube. And problems of decontamination and tracheocutaneous fistula, tracheostomy scar occur. So please do learn and do give some time to these complications, because any scenario type questions can come out with these complications. So it's one of the example I'm giving you. A 70 years old male with carcinoma of larynx and stridor for the last 2 months is brought to the emergency department. Emergency tracheostomy is carried out. When the trachea is open and tracheostomy tube is placed in the trachea, it is observed that the patient is not breathing. So what would be I have just told you. So what has happened to the patient? Diagnosis is apnea, because following opening of the trachea in patient who had prolonged respiratory obstruction. How will you manage the patient? The other question. So sudden washing out of the CO carbon dioxide, which was acting as a respiratory stimulant. And so again, and this assisted ventilation. So this could come in your viva as well. So please give some time to the tracheostomy, because last time I think complications of few procedures can come. So do remember all these complications of tracheostomy. Now we would shortly discuss the esophagus. What is the anatomy and what are the different conditions of the esophagus. We know that the esophagus is a tube which comes after pharynx, lower end of the pharynx at the level of C6 till at the level of C11, that is gastroesophageal junction. So basically, and if we see this tube is not a straight tube, slightly deflected towards the left side, as you can see. Because this is very important, the procedure you must know, that esophagoscopy, that is we routinely do in our ENT theatres, is that we should know the anatomy of the esophagus. Otherwise, the most important complication of the esophagus would occur, that is the perforation of the esophagus. So you can see that this is slightly tilted towards the left. Again, the important thing we need to remember that there are 3 constrictions present in the esophagus. The first constriction, which comes from the teeth to the C6, that is about 15 centimeters. Total length of the esophagus is around 40 centimeters. So esophagoscope is of 40 centimeter length. So first constriction occurs, which is called gastroesophageal junction, comes at 15 centimeters at the level of C6. The other is where it passes the arch of aorta and also the left lung. That is at the level of between the T4, low level of T4 at the level of 25 centimeters. While third is where the esophagus enters into the diaphragm. It is around T10, which is 40 centimeters. So you should remember these constrictions of the esophagus. And again, first 2/3 of the esophagus, there are different types of 4 types of layers present. That is, there are different types of muscles present in it. Upper 2/3 is striated muscles. Middle portion is the lower 1/3 is smooth muscles. While in between, there is a combination of striated and the smooth muscles. So this is one of the anatomy of the esophagus. Now these are a few, because the function of esophagus is passage of the food, and again because there are 2, of course, sphincters are present, upper esophageal sphincter and lower esophageal sphincter, and these sphincters, they constrict and relax during our peristaltic movements. So there are different clinical conditions associated with the esophagus are acute esophagitis. It is an acute inflammation of the esophagus. And causes are, of course, that there is ingestion of hot liquids, caustic agents like corrosive agents, alkalis and acids, which are routinely present in our home, like sweeps and different types of detergents which are present. And sometimes, of course, in the case of kids, foreign body laceration, esophagoscopy, trauma, candidal infection, thrush. These are some of the conditions which can cause acute esophagitis. And what are the symptoms? The presenting symptoms of patient are dysphagia, and retrosternal burning, and hematomas. These are the clinical features which come most of the cases of the esophagitis. So the diagnosis, of course, the history matters a lot. You need to take the complete history and X-ray both lateral view and PA view is very important in the case of acute esophagitis, just to see is there any inflammation, any there is a swelling of the esophagus. But the important thing, the clinical diagnosis would be confirmed with the help of esophagoscopy. That's why I'm stressing on it that you should know that the anatomy of the esophagus. So treatment according to the cause. If whatever the cause, treat according to the cause. Now, perforation. This is one of the important, problem of the esophagus, which could be very fatal. And what are the causes? Either instrumental, yes, esophagoscopy that we are routinely do in our theaters. It could cause your perforation in esophagus. And what are the spontaneous rupture? One of the conditions in which a lot of vomiting occur, and there's and that condition is called, and in this case, is a rupture of all layers of the esophagus, and that is called boiler head syndrome. And how we will diagnose these conditions? Again, there are two we can divide it into cervical esophageal rupture or thoracic cervical rupture, because in both cases the symptoms are different. You can see that if there is a cervical esophageal rupture, then the presentation would be a lot of pain in the neck, fever, dysphagia, and local tenderness, and surgical emphysema in the neck. Whenever you touch the neck, there would be some cracking sound in the neck. And what is thoracic esophageal rupture is pain referred to the pain is not in the neck, but in the intrascapular region. Fever would be very high, that is around 1 or 2 to 1 to 4 degrees Fahrenheit. Definitely signs of shock are present in it. And surgical emphysema neck, again, this is a crunching sound. And there's some another important that there is a sound over heart that is called Hammond sign in mediastinite. In the air in the mediastinum due to mediastinitis. And there could be pneumothorax because it is below the, it is in the thoracic region. So again, I have already told you the diagnosis could be made by the X-ray night chest, AP view, and also the esophagoscopy. And treatment is immediate treatment is nil per hour. We are just free the whole esophagus by taking any feed, and we would give them intravenous nutrition as well as a lot of antibiotics just to combat the infection. And then if there is a ruptured esophagus, then conservative management is very helpful. But in the case of thoracic esophagus, it is quite fatal and serious condition. If we are not able to treat it within 6 hours, then what would happen? We need to prepare it surgery. So delayed may be up only during the infection less time. So this again, the other condition is corrosive bugs of the esophagus, as we can see. Again, this condition either accidentally we can take the different chemicals, or consciously due to any due to any suicidal attempt. Then this is the condition. Again, the infection would be what would happen? There is a perforation of the esophagus. So the question comes over here: either acid or alkali, which one is more dangerous? And in this case, alkalis are more dangerous because it will rupture the whole layer, 4 layers of the muscle, mucosa, some mucosa, muscles, and then adventitia, whole layers of the would be, damaged by taking alkalis. And in adults, with corrosive alkalis, these are different things which we can use in the caustic soda, potassium hydroxide, ammonia, and corrosive acids are sulfuric acid, nitric acid. This is comparatively less, although it is again very dangerous, but less dangerous than the alkalis. So you can see this is the esophagogram done, and you can see there perforation. Due to perforation, there should not be anything present around here. But you can see due to perforation, leakage, you can see the contents of barium swallow. Whenever we give the barium swallow to see the perforation, and you can see that there is something present outside the esophagus. You can see over here. So basically, again, I have told you the underlying pathology, and there are 3 conditions. There are 3 stages in the esophageal burns. Stage of acute necrosis means starts immediately, lasts for 1 to 4 days. Stage of granulation, first slough separates, leaving granulating ulcer 5th day. And stage of stricture begins at 2 weeks, continues for 2 months. So you can see stricture means that this is the condition where we should intervene with an surgical intervention is needed over there. So how can we evaluate the patient? Cause history, proper full thorough ENT examination, and this radiological examination as well. And then determine the type of the plastic. Of course, we need to, in history, we need to find out the type of ingested chemical as well as quantity, and of course these are the signs symptoms of the shock, peripheral airway obstruction, any signs of mediastinitis, peritonitis, and we need to radiological examination will definitely give us the picture of the perforation, site of perforation, and the type of perforation, and so what is the management? Was immediately hospitalize the patient. Although I'm telling you, there's those patients who are doing, who are taking corrosives, they need lifetime follow-up in the hospitals. So, but in the immediate management is just to hospitalize the patient, treat shock, and monitor urine output, because these patients can go easily into the renal failure, and relieve pain, injectable analgesics, relieve airway obstruction, tracheostomy should be done. And if we have the time, that is the patient comes within the 6 hours, then we can neutralize the arteriosity by antidotes. And a lot of antibiotics should be used for a longer period of 3 to 6 weeks. And of course, we would pass the NG tube for feeding. And there are basically 2 reasons, for feeding as well as for maintaining our urine. And esophagoscopy, immediately we are unable to do it, but after 2 days, just to know the degree and extent of the burn. After 2 weeks for bougie dilatation. Steroids are helpful to prevent stricture, and follow up every 2 weeks with esophagoscopy. So, what are the, if the stricture would come, what are the treatment options in those cases? There is stricture treatment. Esophagoscopy should be done. That should be done from the mouth. So, and we will do the prograde dilatation, that is with the help of bougie dilatation, if permeable, through the mouth. In gastrostomy, we make a hole in the stomach, and then we will do the retrograde dilatation. And then the third one, if the stricture are formed and we are unable to treat with these procedures, then we will go for esophageal reconstruction. Difficult procedure, but we will do that. In this case, be removed, and then the other area should be joined by the colon or jejunum. So you can see these are different types of holes of perforation. You can see that the hole in this is not the humor of the esophagus after dilatation. So you can see the hole is so small. You need a continuous dilatation. Bougie dilatation. Bougie is a simple plastic tube which should be repeatedly passed into this esophagus just to make this hole a bigger one. So you can see This would occur after Buji dilatation, but we need repeated Buji dilatation to get uh, this type of hole in the esophagus. Now, benign strictures of esophagus, yes, strictures occur when muscular layer of esophagus is damaged. These are the strictures of esophagus. Again, causes, you must remember that burns, trauma, ulcerations, and these are the conditions. Sometimes in congenital, you can go one third of portion of esophagus. These are some of the causes for the benign strictures. And again, presentation would be the same, that is dysphagia as well as regurgitation, cough, and pain. Patient must be malnourished because he can't take proper food uh, continuously. So, barium swallow establish the diagnosis. This is the most important choice of investigation. That is the gold standard investigation is the barium swallow. That is esophagogram. We just saw the X-ray, and this will establish the diagnosis. And then it will decide either we should go for esophagoscopy and to exclude the pregnancy, because it is in benign strictures. Again, there is 1 to 10% chances of getting malignant. So treatment again the same, that is esophagoscopy. Either we will do the dilatation with the Bujis, and if the case is severe, then we will go for surgical intervention. So again, there's another condition that is called hiatus hernia. That is, hiatus means holes. It is a displacement of stomach into chest to esophageal opening of the diaphragm. Mostly occurs after in adult patient after 40 years of age. There are two types of condition. Either it is a sliding one, the whole stomach then will enter into the pass through the diaphragm into the passes through this is a basically this is basically whole sliding hiatus hernia, right? This you can see the whole stomach can pass through the diaphragm. While in the case of low esophageal, this is the paraesophageal hernia, that is the portion of the stomach along with whole its layers can pass to the side of the esophagus. This is called sliding hiatus hernia. So again, these are condition. Again, clinical features would be no reflux esophagitis, sometimes dyspnea on exertion after meals due to presence of stomach in the chest, and hematemesis. Definitely dyspnea would occur in hematemesis due to peptic ulcer in the part of the stomach. So again, how can we diagnose this condition? The gold standard investigation would be barium swallow, and treatment, of course, surgical treatment is required over here. Hernia reduced and diaphragmatic opening is repaired. You can see this is the condition. These are the hiatus hernia would be repaired. You can see this. So, Vincent syndrome, again, this comes a lot of times in our paper in the form of SAQ, and it can also occur in the MCQs. So, Vincent syndrome, which is a Peterson Brown Kelly syndrome, predominantly it occurs in the females more than 40 years. Classical presentation of this. And whenever you get the scenario-based question, then you will definitely get the classical picture of this. That is, what are the clinical features? You can see these are the clinical features. These are polynychia, spooning of the nails, angular stomatitis, and glossitis, as you can see over here. And whenever we go for, because in this case, how we can diagnose it, again, barium swallow will definitely tell the diagnosis. And we will go for esophagoscopy just to see see this web. Let's see this web. Web formation in esophagus near post-liquid area. So this is close to this area, and around 10% of the patient will get into this carcinoma. So this is very important. The condition is important for this reason, that because it can only 10% of patient, but this condition can be malignant. So treatment, again, of course, treat all the symptoms, because we need to treat the anemia by giving the iron, and need to give the B12, B6, all these vitamins should be proper. And then if the webbed area is present, then we will go for dilatation with the bridges. Morbus hystericus, this is a functional disorder. Mostly occurs in the young girls, and they present with a feeling of lump in the throat. And there's when the important clinical examination we can do in our OPD, let's just ask the patient to different questions, of course, and cough. And feeling of lump is more marked between meals. Yeah, if you see the whole ENT examination should be done, then it is most of the time clear. So the important treatment is just to reassure the patient because there might be some psychiatric element present in those girls. Now some motility disorders is the hypermotility and hypomotility disorders. In hypermotility disorders, some condition like esophageal valves, diffuse esophageal valve, and nutcracker esophagus will occur. By hypermotility, cardiac eclampsia, one of the important conditions. GERD, this is the most important condition nowadays. Gastroesophageal reflux disease and scleroderma. And these involve sphincters. So one of the conditions is epipharyngeal spasm. Basically, there is a failure of upper esophageal sphincter to relax properly. You need to know there is failure of upper esophageal sphincter to relax because this will give the different symptoms to the patient. The presentation will be different. And the underlying pathology is that there is incoordination between relaxation of the upper esophageal sphincter and simultaneous contraction of the pharynx. So causes CVS, Parkinsonism disease, and multiple sclerosis. And what we you just treat the cause. In this condition, just treat the cause because most of the case these reflux. Again, the symptom would be the same, that is reflux and heartburn, and substernal pain. And diffuse esophageal spasm, which is again called corkscrew esophagus, non-peristaltic. In this case, there is a non-peristaltic contraction of the body of the esophagus, while sphincter relaxation is normal. Again, the difference between two conditions. In which there is the upper esophageal sphincter is not properly relaxed, while in this case, sphincter is normal. So, symptom dysphagia, odynophagia, and substernal chest pain. Again, barium swallow will establish the diagnosis. And treatment would be a dilatation of the lower esophagus and myotomy in some cases of the condition. We can see this picture. You can see this corkscrew to pull up the cork of a bottle type. This is the condition of esophagitis. Diffuse esophagitis, spasm in the esophagus. You can see there are different non-peristaltic contractions. This type of. Now condition is cardiac eclampsia. Eclampsia means not opening as stenosis. It is characterized by absence of peristalsis in the body of esophagus. There is complete absence of peristalsis with failure of lower esophageal sphincter to relax during swallowing. So symptom would be dysphagia, more for liquids, as solid may empty due to weight, and the regurgitation of course occurs, and diagnosis would be done with the sparrow, and this will show a specific picture of rat tail lower end. That is called bird beak appearance also. You can see in this case. You see this type of appearance. Classic bird beak of eclampsia. Or in other words, we can also say that these are rat tail appearance. So this is one of the classic picture of the cardiac eclampsia. So again, treatment will be elevation of the there's a surgical treatment for the eclampsia cardia. That is Heller's operation. You need to learn only the name of this procedure. In some cases, myotomy can be done. You can see in this case. Now, GERD, that is gastroesophageal reflux. This condition is routinely present in our patients nowadays due to our lifestyle and late dinners and a lot of spicy or oily foods we take during late night meals. So this is the condition. Most of the patients they present with the GERD, and this condition later on affect our larynx also. So sometimes patient presents with the laryngitis, and if we take the history of GERD, then if we treat it properly, most of the patients' voice would be normal after taking proper medication or proper learning of or changing of lifestyle. Then GERD could be treated easily. It is a regurgitation of gastric contents into the esophagus. Etiology, of course, this is a pathology that decreased function of the esophageal sphincter. Some pregnant ladies, this is the common condition. Hyperthermia, scleroderma, increased use of tobacco or alcohol. Drugs that relax muscles, anticholinergics, atropine, adrenaline. So symptoms would be, I think, more or less same in most of the conditions of the esophagus, that is substernal pain, heartburn, and regurgitation. So again, what I have already told you that ideal treatment is change of the lifestyle and taking food 3 hours before time. This is one of the elevation of the head of the bed and antacids, drugs that decrease tone of the sphincter, metoclopramide, Maxenon you can take to sometimes we should give to the patient as well. And then H2 receptor antagonists, matadine and natadine. This is a very good drugs which should be used after meals and especially early in the morning without taking anything. And of course, we tell the patient to avoid smoking alcohol and caffeine, especially at night. Complications again, there could be occur Barrett's esophagus, which could occur, and aspiration pneumonia. It could also affect the lungs, so it would come with the symptoms of asthma, bronchiectasis, and of course laryngitis. And these are laryngospasm, continuous clearing of the throat. These are signs sometimes very rare, but carcinoma of the larynx would occur in this patient. You can see these the lower esophageal sphincter. So it is open and the contents can regurgitate into the these are the conditions. It is normally called acid reflux. Now condition comes as carcinoma of esophagus. In this case, 93% is carcinoma, and etiology is same, that is smoking, alcohol, tobacco chewing, and of course all the condition like benign strictures, hyperthermia, cardiac eclasia, pulmonary syndrome. This is one of the complication of the carcinoma esophagus. And basically it can spread directly into the lumen and of course infiltrate the wall of the esophagus. Then there would occur perforation of the esophagus, and it would also involve the adjacent structures like trachea, bronchus, aorta. Then the presentation would be dyspnea or some cough, and involvement of weaker laryngeal nerve causes aspiration problems as well. So this is a direct spread. Lymphatic spread can occur with the cervical, nose, and blood borne, of course, liver, lung forms there. So clinical feature again would be the same, but in this case, of course, if it involves the distant structures, then the presentation would be, the involvement of these things. So cough, hoarseness, aspiration pneumonia, mediastinitis. So diagnosis by breathing swallow, and this will again rattle appearances, some malignant strictures. Esophagoscopy is done for just to get the size, extent, and we also therapeutic in the care by taking biopsy from the involved area, and bronchoscopy to exclude the extension to trachea and bronchi, and CT scan. So in this condition, if the extent is to the adjacent structures, then we will go for fan endoscopy, and fan endoscopy involves esophagoscopy endoscopy as well as your nasoendoscopy. So you will try to examine all the involved structures properly and take biopsy from any adjacent area if it is involved. CT scan, of course, radiological investigation needed for extended node metastasis. Sometimes nodes are invisible. So we need to, this CT scan gives a lot of good information regarding the extent of the tumor as well as the nodal metastasis. So treatment upper two-thirds, it is radiotherapies we can give, while by lower third surgery, the stomach pull-up, and in advanced cases palliation would be ideal because you need to just give the palliative treatment to the patient and just to give them their symptomatic treatment. In those conditions, just to bypass in elderly patients, esophageal intubations, gastrostomy, jejunostomy, laser surgery, these are few conditions which are advanced cases. So we need to give them palliative treatment. And prognosis is 5 years survival into only 5 to 10%. So prognosis is not very good. You can see that this is a picture of the fellow. Actually, you can see the rat tail appearance. This is different types of strictures. You can see perforation. And this is basically stomach pull-up. You can see this. There's a tumor present over here. You need to remove the tumor, and then whole cancerous area should be removed, and then the stomach should be pulled up to join with the esophagus. This is the final result of the stomach pull-up. This part is removed, and this continuously remaining part of stomach is joined to esophagus. This is one of the conditions we can do for the esophageal stenting in carcinoma esophagus. That is carcinoma obstruction as seen through the endoscope. You can see this is the tumor area, and you can do this pass this dilator, then you can use it to stent. Expandable metal stent fully deployed restoring the lens. But this should be done in advanced cases as palliative treatment. The expanding stents for intubation advanced serious esophagus. If you want to ask any question, then please you can